I think there is a connection issue. Is it?
Yes, doctor.
It's just
Your
showing
voice is
some connection.
yes. Your voice is breaking in between. I think you can try turning off your camera.
All right. All right. Okay. So very good evening to one and all. This is our third session of the week. I'm glad that we have among us a very senior, seasoned faculty who not too long ago had received a Lifetime Achievement Award from the Delhi Neurological Association for her contribution to neuroscience in the year 2017. She is Dr. Mary Abraham. She is a neuroanesthetist and a pain and palliative care personnel. She is a visiting consultant at various prestigious hospitals across New Delhi, Max Hospital, Institute of Cancer Care, Indian Spinal Injury Center, also as a private clinic. Her main interest, as I already told, she is neuroanesthesia, and she is very much into the core of pain and palliative care. She has also authored a book named as Conquering Pain in the year 2019. Ma'am, extremely delighted and an honor for us to have you amongst us to conduct a session for all doctors. Welcome to you, ma'am. Over to you. Ma'am, you're muted, ma'am. Your mic is muted.
Now, am I clear?
Yes, ma'am. Perfect.
Yes, ma'am. Yes, you're audible.
Okay. Now, what do I do? Okay, thank you, Deepak, for that warm introduction. And thank you, Shri Priya, for conducting this program. And once again, it's my delight and pleasure to take this class for all the pain and palliative care physicians who are collected here who want to learn more about palliative care. So I'll just start my presentation. I'll be talking about, the broad outline would be, I'll be talking about the WHO analgesic ladder with reference to step 1 and step 2 drugs. And also I'll be touching upon the adjuvant drugs and drugs used for neuropathic pain. So that would be the topics I will cover in today's talk. Now coming to the WHO analgesic ladder, am I audible?
Yes, ma'am, you are.
So the
Yes, audible and clear, ma'am.
Thank you. So the WHO analgesic ladder was based and devised on the recommendations of a group of international experts who met in 1986. It was basically to manage cancer pain, and subsequent to 1986, now it has been more than nearly 3 decades or 4 decades. It has been translated into 22 languages and its use for treating cancer pain worldwide. So it is still a very popular tool to treat cancer pain. It is a stepwise approach to treat cancer pain depending upon the intensity and severity of pain. So that is the criterion we use to apply the ladder, the severity of pain. And prior to this, patients were dying in, if you don't mind, can I just take a break? I'll just take this call if you don't mind. Huh?
Yes.
Hello? Hi.
You're muted, ma'am. Still muted.
Ma'am, you are muted.
I would like to apologize for this call that I had to take. It was a very urgent call. That's why I took it. Okay.
No worries.
I'm so sorry. Normally, I don't take calls during the presentation. Okay. So the WHO analgesic ladder is a stepwise approach to treat cancer pain depending on the severity of pain, like I told you. Okay. Now, prior to the WHO pain ladder, people were dying due to unnecessary pain. One reason was that there was a lot of drug regulations and restrictions associated with the use of opioids prior to 1980s. So the doctors were hesitant to prescribe opioids, and patients and relatives were very wary of taking it, thinking that they will get addicted to it. And also there was a lot of stigma associated with prescribing and taking opioids. As a result, opioids or the step 3 of the ladder was not being used at all, and people were dying with pain. But when the WHO introduced this ladder, it actually legitimized the use of opioids. So then it gave people courage to use opioids because the WHO themselves have endorsed it. Okay. Now, next. Okay. Now, I'll start with a small case presentation. A 35-year-old father of 2 young children. He had squamous cell carcinoma in the right upper lobe. He had the pain, which was a deep-seated gnawing pain in the right shoulder, but also associated with a burning and tingling pain in the right arm. He was unable to sleep. The NRS was 4 during the day and 6 at night. So at the end of this presentation, let us see how we can manage this patient. So like I said, to apply the ladder, before that, we need to do a comprehensive assessment of pain, which I think would have been dealt with in the earlier classes. So there is this mnemonic PQRST, U. Okay. So in this PQRS, the S stands for severity of pain, and that is the important thing that you should know before you apply the ladder. So after you do the assessment, you must know the severity of pain. The other thing we need to know is what is the kind of pain? Is it a nociceptive or neuropathic, or is it a mixed pain? That is a combination of both nociceptive and neuropathic. Now, when you want to apply the ladder, this ladder is a 3-step ladder with step 1, step 2, step 3. So in step 1, that is for mild pain, where the NRS is less than 4, then you have to give a non-opioid analgesic with or without an adjuvant, okay? Depending upon whether there is other components to the nociceptive pain. But if the patient is not responding to step 1 drugs, or if the pain is in the moderate range, in a NRS score of say 5 to 7, then you will add on a weak opioid to the non-opioid drug, with or without an adjuvant. Okay. Now, if it is not responding to this also, then you move to the step 3 drugs. That is, you substitute the weak opioid with a strong opioid, along with a non-opioid drug. But sometimes when the pain is very severe, you can directly move from step 1 to step 3. Or sometimes when the patient is coming with very severe pain to the OPD, then you can do what is called a morphine titration and then start with step 3 drugs also. So it is not rigid that you have to go as 1, 2, 3. It all depends upon the clinical condition and the degree of the pain the patient is having. Now, using this 3-step ladder, nearly 3/4 of cancer pain can get satisfactory relief. Okay. But there is a subset of patients who may not respond to even the 3 drugs. Now, what are the salient features of the ladder? The first is that the drugs are given by mouth. By mouth means the oral route is a standard route. Even for the strong opioids like morphine or, that outside they give drugs like oxycodone and hydromorphone and all. No? Now, in India, we are using only morphine, and the oral route is a standard route. And the advantage is that it can be given in home. Patients can be, relatives can be taught how to give the medicine, or the domiciliary nurse or the visiting nurse can give the medicines, right? So the patient need not be hospitalized to get this drug. That is the first rule, that is, it's by the mouth. The second is by the ladder. By the ladder is, like I said, you can start with step 1 and move up the ladder depending upon the severity of pain. The third important criterion is it is given by the clock. That means you give it according to the duration. The second dose is given according to the duration or the half-life of the drug. For example, we know that morphine, immediate release, acts for 4 hours. Its half-life is 4 hours. So at the end of 4 hours, you have to give the next dose of morphine, because otherwise the pain will escalate and you'll have peaks and valleys. So you don't have a continuous relief of pain. Okay. So idea is not to have the peaks and valleys, but to give a good relief throughout the 24 hours. So for that, you need to give it by the clock. So when you tell the patient and write the prescription, you must also facilitate it by telling that these are the timings. You maintain a chart and give it according to the time. For example, paracetamol is given every 6 hours. So again, you can tell them that if you give it at morning at 6 o'clock, then next dose you give it at 12 o'clock. So you have to help them and tell them that you don't wait for the pain to return, but you go by the clock. Otherwise, like I said, the breakthrough pain can occur. Another thing we should keep in mind is it is individualized to the patient. So the right dose of analgesic is the one that is completely relieving the pain of the patient. So in one patient, you can get good relief with 30 milligrams morphine. In another patient, you may go up to 300 mg morphine. But 300 would be the right dose for that person because that is the one that is producing the complete pain relief. So also you have to tell them that in between this period, in between 4 hours, if there is a breakthrough pain, how do you treat it? So all these has to be individualized to the patient. So all the instructions have to be given very clearly. Then, like I mentioned, at every step of the ladder, you use adjuvant drugs. They are used to treat specific types of pain, and it helps in decreasing the undesirable side effects of some of the analgesics. And attention to detail is very important. You have to take into consideration the age of the patient, the body habitus, the body weight, the comorbidities, and whether the patients are on any other drugs. Everything has to be taken in consideration when you're writing the dose of morphine or any drug for that matter, whether it's paracetamol or whether it's NSAIDs. We have to look into all this when you're writing out the prescription. Now, the advantages of the WHO ladder is, it is like I showed you, it's very simple, easily understandable. Even when you explain it to the patient's caregiver or patient's attendant, they understand it. Okay, it is very good to keep them in the knowledge of this, that this is how I'm planning to treat it. I'm planning to start with step 1 drugs. If it is not responding, only I'm going to step 2, and then only I will go to step 3. If you tell that to them, they will also understand what you're trying to do. It is a validated tool. That means using this ladder, it is, sorry. And Dr. Rana? Yes. Sorry for the interruption. So the WHO ladder is a simple and easily understandable thing. The advantages: it's a validated tool. It is effective and very cost effective. You know, the drugs like morphine and paracetamol and all are very inexpensive drugs. It can be implemented across the world, even in underdeveloped countries, well suited for home care. It can also be used for acute pain and chronic non-cancer pain. For example, a patient has fracture or a patient has got post-operative pain, you can apply the ladder even in these patients. Now, there are certain modifications of the ladder. Like I mentioned, you can omit step 2 and go to step 3. You can also add a 4th step because those patients are not responding to step 3. You can add a 4th step. So this was a modification in 2000 in which the 4th step includes certain interventions that you can do. And they include nerve blocks, epidural injections, patient control analgesia pumps, or neurolytic block, spinal cord stimulators, or intrathecal opioids. Okay, this is for the subset of say 10 to 15% of patients who are not responding to step 3 also. Okay, we can discuss this more when I take the next class on difficult pain. Now coming to the step 1 drugs. The step 1 drugs are basically used in treating mild to moderate pain. They include paracetamol or acetaminophen as it's called in the West. Also, you can use non-steroidal anti-inflammatory drugs and it can be combined with an adjuvant drug. So the paracetamol has a predominant central action. It inhibits the enzyme cyclooxygenase in the central nervous system, and it has no effect on peripheral COX. It is basically an antipyretic and analgesic action, but it has no anti-inflammatory action. Okay. That you can keep in mind. The dose, I know you people need not know all this, but still I will just tell. It is safe in a dose of 12 to 15 mg per kg every 6 hours. You can go up to 3 grams a day. The daily dose should not exceed 4 grams and a single dose should not exceed 1 gram. Normally, we give in a dose of 650 mg every 6 hours. We also have sustained release paracetamol tablets of 1 gram, in which 300 is released immediately and 700 is released over a period of 12 hours. We can also give paracetamol as an IV infusion, 1 gram every 6 hours. And sometimes when the oral route is not feasible, like for example, for oral cancer and patients whose mouth opening is not adequate, who can't swallow, you can use a rectal route also. Very safe for pediatric use in a dose of 15 mg per kg every 6 hours. And toxicity occurs only in doses of more than 90 milligram per kg per day. Now, what is NNT? NNT is the short form for numbers needed to treat. So it is basically judging the efficacy of an analgesic. That is, it is a number of patients who receive an analgesic for one to have 50% pain relief over the next 6 hours compared to a control. So for paracetamol, the NNT is 5. That's not a very good number because for every 5 patients, only 1 patient will have good pain relief. So as compared to ibuprofen and diclofenac, which have got lower NNTs. So the advantages of paracetamol, why it is so popular in the WHO ladder, is that it has a very good safety profile. It has no adverse effect on gastric mucosa and well tolerated by patients with peptic ulcers. No adverse renal effects, no effect on platelet function. It has got, the 2/3 of patients who are hypersensitive to aspirin can tolerate paracetamol. So allergic manifestations are less. And it also does not affect the plasma uric acid levels. But the drawbacks are that you have to give it every 6 hours. It has no anti-inflammatory action. And it has the potential for hepatotoxicity when you give in high doses of 4 grams a day, more than 4 grams. Those with impaired liver dysfunction, impaired liver function, those who are excessive alcoholics, whose body weight is less than 50 kg, you restrict the dose to 2 grams. But even in those with liver disease, you can go up to 2 to 3 grams a day safely. So like I said, we have used paracetamol at every step of the ladder. Okay, so it has a good safety profile. It has an opioid sparing effect, and it can be given very well in combination with the NSAIDs and tramadol and opioids. Now coming to the other step 1 drug, which is a non-steroidal anti-inflammatory drugs. So this exerts its therapeutic effect by inhibiting the peripheral cyclooxygenase, unlike paracetamol, which inhibits the central cyclooxygenase. Now, peripheral cyclooxygenase, COX, is a very important enzyme in the arachidonic acid cascade after tissue injury, which produces the tissue and inflammatory prostaglandins. Now, prostaglandins are very important intermediaries in pain and inflammation. And because of the release of prostaglandin, there is what is called the amplification of pain and peripheral sensitization. So these are mainly used in the treatment of nociceptive pain. So here, if you look at it, whenever there is a tissue damage, there is a release of all these tissue byproducts. Okay, and inflammatory mediators like bradykinin, prostaglandins, and all. So they form what is called a sensitizing soup around the peripheral nociceptor. Okay, and this sensitizing soup is the one that is amplifying the pain. So here, if you look at it, this is a peripheral nerve ending, the first order neuron, and this is the nociceptor. So when there's a tissue damage, there is a release of all these substances, right? And the NSAIDs are actually acting at this level. It is acting as an anti-inflammatory effect and counteracting the effect of the peripheral of the prostaglandins. So here also you can see it is at this level that these COX inhibitors are acting. Now you must remember that COX exists in 2 forms. One is the COX-1, which is present in all normal tissues and it's physiological. It is called the constitutive or the housekeeping enzyme because it mediates the physiological responses for protecting the stomach and the kidney and facilitating platelet aggregation. So that is very essential for our body. But it's a COX-2 that is released following inflammation. It is called induced because only when inflammation happens that this is released. Like I said, tissue injury, phosphoglipids, arachidonic acid, this is converted to prostaglandins because of this COX-2 inhibitor. Now, what we need to do is we need to stop this and not this, because this is very important. COX-1 is very important for the body. But COX-2 is the one that you need to counteract. Okay. Now, non-steroidal anti-inflammatory drugs are of two types. One is the non-selective, which is interfering with both COX-1 and COX-2. The second is the selective COX-2, which it interferes only with COX-2 and COX-1 is paired. So the non-selective, if you look at the classification of the non-selective anti-inflammatory drugs, you have the salicylates, which are aspirin, the propionic acid derivatives, which are ibuprofen, naproxen, and ketoprofen, and then the aryl acetic acid derivatives, which is diclofenac, and then piroxicam, ketorolac, indomethacin. So this is a basic classification of the non-steroidal anti-inflammatory drugs. Now the non-selective anti-inflammatory drugs. The prototype for this is brufen, ibuprofen. Okay, it inhibits both COX-1 and COX-2. Because it interferes with COX-1, it exerts the adverse effect. So it causes the GI side effects like bleeding, hypersensitivity, and the adverse renal effects, and the effects on the platelet function. But because it inhibits COX-2, it has a beneficial effect because it is acting as an anti-inflammatory, analgesic, and antipyretic. So the non-selective NSAIDs is a double-edged sword with both adverse and beneficial effects. Like I said, one is ibuprofen, and it has got a very good NNT. That means 2. For every 2 patients, 1 will have good relief. And naproxen, that also has a very good NNT of 2.7. We remember I said paracetamol has got 5. Okay, so compared to that, these are more potent analgesics. But the only disadvantage is it is inhibiting the COX-1 enzyme. Now, because of the COX-1, I said you have all these disadvantages: renal problems, gastrointestinal problems, and hypersensitivity reaction. And also platelet, I forgot to write that, even platelet aggregation is also impaired. Now coming to the selective COX-2 inhibitors. So they are inhibiting only COX-2 and COX-1 is paired. So it's supposed to be good, right? So the enzymes, the drugs that we have are etoricoxib or leucoxia. You can give as a single dose, 60 milligram, 90 milligram for 120 mg as a single dose. Then you have celecoxib, which can be given 100 or 200 mg twice daily. And diclofenac is functionally a selective COX-2 inhibitor because it can spare the stomach, but not the kidney. I'll talk about it later. It has got a very good NNT of 2. We also have topical NSAIDs. It produces some analgesic effect with less risk of systemic absorption and toxicity. For that, various gels and creams containing ibuprofen, diclofenac, piroxicam, and ketoprofen are available. Now, the question we need to ask are selective COX-2 inhibitors safe as compared to the non-selective COX inhibitors? Now, like I said, where the GIT is concerned, it is safe. That means it does not have the adverse GI effects. But where the renal damage is concerned, it is comparable with the non-selective NSAIDs. On the other hand, it has got the disadvantage that it is prothrombotic, and there is more likelihood of myocardial infarction and stroke. In fact, selective COX-2 inhibitors like rofecoxib was taken off the US market in 2004 because of the incidence of these thrombotic events. So in such patients who are at risk of thrombotic events, the safe NSAIDs to give is ibuprofen or naproxen. So if you look at the risk factors for NSAIDs toxicity, so these are some of the risk factors for GI toxicity. These are for the renal toxicity, dehydration. Just remember, patients should be well hydrated when they are giving NSAIDs. And also for stroke and MI, COX-2 drugs can cause problems. So those patients with history of TI or stroke or previous history of MI, then you have to be very cautious when you're using COX-2 inhibitor. Now, let's move on to the step 2 drugs. These include the weak opioids, and these are not controlled drugs. So they are more easily available and they are widely used. They are given for pain of moderate intensity that is not controlled with step 1 drugs. And the examples that I will talk about are tramadol and tapentadol, because that is what we are using now in India. Now coming to tramadol. It is a centrally acting synthetic weak opioid. Now just remember, it has a dual mode of action. Because it's a weak opioid, it has less tendency for respiratory depression and addiction potential as compared to the stronger opioids. But it also has a non-opioid way of action, and that is by blocking the presynaptic reuptake of serotonin and norepinephrine. So it acts on the descending inhibitory pathway of pain. So it is also very effective for neuropathic pain because it blocks the reuptake of serotonin and norepinephrine. It is a prodrug. That means it is converted to active metabolites for its analgesic effect. And we are widely using tramadol and paracetamol as a step 2 drug, very commonly used for cancer patients or even for other kind of. Now, it has a very high oral bioavailability. Its plasma half-life is 6 hours. The oral dose is quite potent. It's 1/10 potent as morphine. So when you're giving 400 mg tramadol, its equianalgesic morphine is 40 mg. You divide it by 10. The dose is 50 to 100 mg every 4 to 6 hours, and the maximum dose should not exceed 400 mg. Sustained release formulations are also available, which can be given twice daily. But it has got some side effects like nausea, vomiting, dry mouth, constipation, sedation, dizziness. There could also be seizures when the total dose exceeds 400 mg, or when you give it IV rapidly, or when you use with drugs that lower the seizure threshold like tricyclic antidepressants and SSRI drugs. The other step 2 drug is tapentadol. It is considered a weak opioid, but of late, it has also been thought to be a stronger opioid as compared to tramadol. It also has the same dual method of action like tramadol, that is, it acts as a beat opioid agonist, and also it acts on the inhibitory pain pathways by preventing the reuptake of serotonin and norepinephrine. It is not a prodrug, that means it has no active metabolism. It has got a better side effect profile as compared to tramadol with less risk of seizures, but you should avoid it in very severe renal and hepatic dysfunction. The dose is very similar to tramadol. The other thing I want to show you is 75 mg tapentadol per orally is equal to 30 mg morphine. As compared to 40 mg morphine is equivalent to 400 mg tramadol. So it is more potent than tramadol where its analgesic potency is concerned. Now, when you want to use any drugs, you have to also see whether it is advantageous or not. For example, we will not combine a COX-1 and a COX-2 drug. Also, do not combine a weak opioid with a strong opioid. But the combinations that are good are combining paracetamol and NSAIDs with morphine, or paracetamol with NSAIDs, or paracetamol with tramadol. These would be advantageous in the sense that they would reduce the side effects and also it will have an opioid sparing. Now let's switch gears and come to neuropathic pain. I told you that we have to also assess the type of pain, whether it's nociceptive, neuropathic, or a combination. Now, 40% of patients with cancer can have neuropathic pain. Also, there are certain subsets that can have bone pain, they can have pain due to bowel obstruction, pain due to muscle spasm, and although other symptoms. It's not just nociceptive pain or tissue damage that is a contributor to the pain. And that is why we have these adjuvant drugs. So the adjuvant drugs, the primary indication is not pain. For example, antidepressant, the primary indication is for depression. but these have analgesic properties as well. They're also called co-analgesics because they are co-administered with drugs of the analgesic ladder. So if you look at the classification, you have what is called a multi-purpose drugs, adjuvants like antidepressants, corticosteroids, or alpha-2 agonists, which are given for a variety of conditions. But there are also specific adjuvant drugs, like what you use for neuropathic pain, for bone pain, for bowel obstruction pain, or for musculoskeletal pain. And I will go through some of these things in this. Now, I mentioned about nociceptive and neuropathic pain. So let's see what it is. One is nociceptive pain is occurring at the nociceptor, which is the periphery of ND, at the site of the tissue injury. Anything beyond this, whether it is the first order neuron or the second order neuron or the spinal cord or the brain, they all come under the category of neuropathic pain. So neuropathic pain is caused by a disease or lesion in the peripheral or the central nervous system. Peripheral is this and central is this. But very often the pain can be mixed also, a combination of both nociceptive and neuropathic. Why do they occur? It can occur because of a direct invasion or compression of the nerve, either basically because of the tumor or the cancer. Okay. Or it could be even because of the treatment of cancer. For example, chemotherapy can cause peripheral neuropathy, radiation can cause neuropathy, or surgical excision can cause injury to the nerve, or even in cancer survivors, where the patient has recovered from cancer, they can still have very severe pain because of the permanent nerve damage. I'm seeing a patient who had CL larynx, who has recovered from the CA. There is no, everything is fine. But he developed a brachial plexopathy because of the radiation. And that has caused severe pain and weakness. Motor power is gone in the arm. So these are the effects of the neuropathic pain. So let's discuss the drugs that are used to treat neuropathic pain. First is the anticonvulsant. This is a first-line treatment for neuropathic pain. And why is anticonvulsant used for neuropathic pain? Because there's a shared pathophysiology between epilepsy and pain. In both, there is neuronal excitability, and this decreases the neuronal excitability. The drugs which are used are gabapentin, pregabalin, sodium valproate. So how do they act? The gabapentinoids, they act at the voltage-gated calcium channels and prevents the binding of the calcium influx. They prevent the calcium influx into the presynaptic neuron. So there is a decrease in the excitatory neurotransmitter that's released into the synapses, and consequently less excitation of the postsynaptic membrane. But they can also act on the sodium channels and also enhance the GABA-mediated thing. But this is a main method of action of the thing. That is, it inhibits the calcium influx into the neuron. So the advantages are very good analgesic effect in neuropathic pain, but it has got side effects like somnolence, dizziness, ataxia, even weight gain, and these should be explained to the patient when you're starting the Now, comparing both gabapentin and pregabalin, both are very good. This is less expensive. This is more expensive. Pregabalin, you can titrate in 2 to 3 steps, whereas gabapentin takes a little longer, but it is also very good to treat neuropathy. Now, topical gabapentin is also available to treat neuropathic pain. And there's another drug called capsaicin, which is a pungent component of chili pepper. 8% capsaicin is supposed to be very good for neuropathic pain, but it is not freely available in India. Now, coming to the other first-line drug for the treatment of neuropathic pain are the antidepressants. Its analgesic action takes a week for it to start, and it is occurring earlier than the antidepressant effect. Okay, so cancer patients quite often have depression, anxiety, and insomnia, so they're very helpful in these patients. How do they act? They act by inhibiting the reuptake of norepinephrine and serotonin at the dorsal spinal cord synapses. So it is activating the descending inhibitory pathway of pain. So if you want to classify it, you have the commonly used drug are the tricyclic antidepressants like amitriptyline, nortriptyline. the selective serotonin receptor inhibitor, the selective serotonin norepinephrine receptor inhibitor, and you have even other drugs like noradrenergic alpha-2 receptor antagonist with specific serotonergic receptor antagonist. That is mirtazapine, which is now being used. And we also have atypical antipsychotics like quetiapine, risperidone, and olanzapine. The ones that are commonly used are the ones that I've highlighted in black. So the three types of antidepressants that are used in cancer pain are, like I said, the tricyclic antidepressants, like amitriptyline and nortriptyline, the serotonin SNRI, which are duloxetine or venlafaxine, and the SSRI, which are commonly used, the escitalopram, citalopram, and paroxetine. If you have to compare all three, the analgesic effect, TCA is more than SNRI, which is more than SSRI. And if you look at the side effects, then TCA has got more side effects as compared to SNRI and SSRI. There are certain side effects of the TCA that we should keep in mind. One is the CNS effects like somnolence, etc., or the anticholinergic effects like dry mouth, glaucoma, cardiotoxicity, orthostatic hypertension, constipation, urinary retention. So these have to be explained to the patient. So your contraindications are these according to the side effects. Now, SNRI, again, you have somnolence, dizziness, etc. The contraindications are that you have to be very careful when you're using in patients with renal or hepatic dysfunction. What are the doses that we give? Normally, if you're starting with amitriptyline, we start with 10 mg, and then you can go up every 3 to 5 days, up to 25 mg, 50 mg, or then 100 mg. When nortriptyline is concerned, again, 10 mg, and then go upwards. Duloxetine, 30 milligrams, you can go up to 60 milligrams. And venlafaxine is 37.5 to 75. And anticonvulsants also, gabapentin, you can start with 100 mg and escalate it up to even 1200 mg TDS. Pregabalin, 75 mg you start with. And normally we start with a night dose because of the somnolence effect. You don't give it in the daytime. Only when they're tolerating the night dose, then we start in the daytime. Remember, adjust all the doses for medically ill patients and those with hepatic and renal dysfunction. Now, this was a study of patients who received duloxetine for chemotherapy-induced neuropathy, and they found that this is quite good for, if you want to treat this, then you give it for 5 weeks after the onset of chemotherapy, it will be effective in treating duloxetine. So the other drugs that we use in neuropathic pain are ketamine. Now, ketamine acts, there's an NMDA receptor that is here in the spinal cord. And this blocks this NMDA receptor, and it's useful for neuropathic pain, particularly if it is unresponsive to antidepressants and anticonvulsants. It has got side effects like dysphoria, hallucinations, nausea, vomiting, and you can prevent it by adding a benzodiazepine. It can be given in a variety of routes, IV, IM, subcutaneous, oral, sublingual, topical, so many ways. And usually ketamine is an anesthetic drug, but in analgesia, it produces in sub-anesthetic doses. So we give only a dose of 10 to 25 mg TDS. Or if you're giving us an infusion, we give only 0.05 to 1 mg per kg per hour, maximum dose of 200. Now we can give burst ketamine infusion for difficult pain, which I will discuss in my next lecture. Now, local anesthetics are also used in treating neuropathic pain, particularly those that are intractable. And what we do is we give IV local anesthetic infusion. Xylocard, 5 milligram per kg, is added to 500 ml of saline and given over 1 hour. And you can repeat it after a couple of days. So they may be effective in neuropathic pain, but topical local anesthetics are also available, like lidocaine patches are now available. 5% lidocaine patches, they can be applied. Except that you should remember that you should apply it for 12 hours and remove it for the next 12 hours to avoid the local anesthetic toxicity. Topical capsaicin, 8%, and topical gabapentin is also available to treat neuropathy. So the first line treatment for neuropathic pain is amitriptyline, pregabalin, gabapentin, duloxetine, and lidocaine patch. And the second line is opioids and tramadol. Now, coming to steroids. Now, steroids is a multi-purpose drug, and it can be given for a variety of conditions like neuropathic pain, bone pain, pain due to intracranial metastasis, pain due to a bowel obstruction, pain due to spinal metastasis. So if you look at all the drugs, we find that dexamethasone is a one that has got the most potent anti-inflammatory effect. It's 25 to 50 times more potent than hydrocortisone. And its duration of action is also 36 to 54 hours. So it can be given as a once a day dose, and that is why we prefer to give dexamethasone for treating cancer. But it should always be given in the morning because it can cause insomnia, and it could provide short-term pain relief and particularly beneficial for those with a less life expectancy. So this is a dose. I won't go into it because I'm running short of time. The GABA receptor agonists also have got inhibitory effects. It's an inhibitory neurotransmitter. So the GABA A agonist is benzodiazepine and GABA B is baclofen. Both are used in cancer. Particularly in the benzodiazepines, clonazepam is the one that has been particularly useful in neuropathic pain. So you give in a dose of 0.5 mg in divided doses. Okay? Or for terminal sedation, also you can give in a dose of 2 to 8 mg 24 hours as a continuous subcutaneous infusion. Baclofen has also been used to treat neuropathic pain in cancer because of it's a new inhibitory, it acts like an inhibitory neurotransmitter. For bone pain, it can cause a lot of problems. So the variety of drugs that are used, which include corticosteroids and NSAIDs, calcitonin, but the latest review shows that it is not significantly improving the quality of life. You can also use bisphosphonates and denosumab or palliative radiation. So bisphosphonates, they are useful for intractable bone pain secondary to a variety of cancers. They act by blocking the osteoclastic activity and the bone resorption. Zoledronic acid is the one that is commonly used, but we must remember that you need to reduce a dose of patients with renal dysfunction. So it's given every week, every month for a year. If you compare zoledronic acid and denosumab is a human monoclonal antibody. Okay, now this is definitely more expensive, but there's less risk of renal toxicity. But it is superior as compared to zoledronic for preventing the skeletal related events like fractures, etc. And if you look at the cost of treatment, then zoledronic, it costs only about 900 rupees per month, whereas denosumab costs 32,000 per month. So it is very, very expensive. Now for bone pain, you can also use palliative radiation. So they are also very effective in treating bone pain. Coming to malignant bowel obstruction, we use a variety of drugs like steroids and octreotide and anticholinergics, and they are useful in treating the pain due to bowel obstruction. And the other adjuvant drugs include the skeletal muscle relaxants, the neuroleptics, and these other drugs that are listed here. So if you look at the pain pathway, so this is a muscle and this is a peripheral nerve ending, and this is how it is going into the brain. You can see that muscle relaxants act at this level. At the level of the nociceptor, the local anesthetic and the non-steroidal drugs are acting. They're also acting to prevent peripheral sensitization. Then at the spinal cord level, here you have the anticonvulsants, antidepressants, opioids, and the NMDA antagonists. And for the descending modulation, these are the drugs that are acting. So various drugs act at different parts of the pain pathway. So you can use a combination depending upon where they are acting. Okay. Now coming back to this patient, I told you about his condition. So how do we treat this gentleman? Now his pain was only mild to moderate, but the pain was a mixed type of pain. He had a gnawing pain in the shoulder and a burning pain in the arm. It was worse at night, and he was also unable to sleep. So how do we treat this gentleman? See, we can give a combination of paracetamol with NSAIDs, right? But we can give an extra dose during the night so that the night pain is covered. So maybe you can give paracetamol 1000 mg or diclofenac SR at night. But we may have to add an anticonvulsant and antidepressant for the neuropathic pain. And add an adjuvant drug like a sedative also. And of course, very important is the psychosocial support that he needs for his financial and social concern. To summarize, the WHO analgesic ladder is a very important tool for cancer pain management. Can be used for non-cancer pain. It's simple and easy to implement. It is used the worldwide, even in the remotest area, and it is legitimized use of opioids in cancer pain. Thank you.
Thank you so much, ma'am. I think that was a rush towards the end, but your slides are so much, it has so much information. I'm sure that, I mean, every doctor here would have been like, I'm sure that they'll have to go through it once more just to get the points which they specifically wish to know.
Yeah, and I'm very sorry for the interruption. Okay, I had to take those couple
That's
of calls.
perfectly okay, ma'am.
I apologize for that.
We understand. Like I understand this is it's a big deal for us that you're able to take at least this much time out from your busy schedule to just provide whatever you're doing, ma'am. So I think we'll take few questions. Please feel free to either unmute yourself, raise your hand, or use the chat box before we move on to the case presentation. So we have a question from Dr.
Good
Rahul.
evening.
Yes, please go ahead, Dr. Tawhid.
Hello, yeah, I'm Dr. Tawhid. So I'm from Bangladesh. I'm working as a palliative care physician in Rohingya context. So my question is about WHO pain ladder. We are using combinations like with paracetamol, with NSAID or opioids. But in case of neuropathic pain, treating neuropathic pain is a bit challenging for us. So what about neuropathic pain? Is there any module to manage neuropathic pain to use any kind of combination, or will in which case we'll select which adjuvant? Is there any guideline like when to use TCA or carbamazepines, or may we use combination of both, or only use a single drug to treat neuropathic pain?
Okay. So in neuropathic pain, like I said, cancer pain is very often mixed pain. In addition to the nociceptive component, there could be a neuropathic component as well. So you should know to diagnose what is the neuropathic pain. Very typical that they'll have burning and tingling and allodynia and all those kind of things. Okay, so the first line treatment for neuropathic pain is adding either an anticonvulsant or an antidepressant, or you can even combine the two. Okay, that's the first line of treatment.
Okay, ma'am.
So you can add gabapentin or pregabalin. You can also add a tricyclic antidepressant or an SNRI. Okay, you can try one, and if it's not working, add an antidepressant also. Or very often I give even both right in the beginning, no problem. There are combinations that are available with gabapentin with nortriptyline, gabapentin with amitriptyline. You can add it. It all depends on the intensity of the pain. If it is mild pain, then you can stick to one. But if it is severe neuropathic pain, you can start with both anticonvulsant. So this is a first line treatment of neuropathic pain.
And
only
if confusion is cleared for me. Thank you.
Good evening, ma'am. Like, is there anything like to select among antidepressant and anticonvulsant?
Okay.
To which we can go first?
Okay. So if the patient has got, like for example, a disc prolapse, okay. Now you have a sciatica pain, which has got a, that tingling, numbness and pain.
Yes.
Usually I start with an anticonvulsant drug, like pregabalin or gabapentin. Okay.
Okay, ma'am.
But if there are a lot of dysesthesias, like allodynia, or the patient is saying like, I don't feel my legs and, they are numb and all those things. then you can add an anticonvulsant, antidepressant as well. But if it is only tingling numbness and a sciatica kind of pain, then I think anticonvulsants are very good. But if there is, like I said, dysesthesias and allodynia and hyperalgesia and all, you can add an antidepressant also. Ideally, in such patients, you can give a combination of both.
Thank you, ma'am.
Good evening, ma'am.
Yes.
Am I audible? Actually,
Yeah,
ma'am,
yeah,
actually,
you
I'm in a very remote setting. So here, many elderly patients come to me of generalized body ache. So in that case scenario, because of the chronic history and also of the local practitioner, they commonly ask for painkillers. So in that case, ma'am, is it advisable to give like paracetamol or diclofenac on a prophylactic basis, or should we go into the depths of it, like finding out the cause and all? Because in my setting, referral centers are very far away, like 50-100 kilometers. So what should I do, ma'am, in this such cases, elderly patients which even refuse to go to the higher centers?
In elderly people, diclofenac you should try to avoid. You can't give diclofenac on a long-term basis, okay? Because it is almost like a non-selective. It can cause kidney function dysfunction. Okay, so in elderly people for non-specific pains, paracetamol is the best. And they respond very well. They respond very well to paracetamol. You stick to paracetamol. Yeah. Paracetamol. And if worse comes to worse, you can even give a combination with tramadol also. Because tramadol, the combination that's available has a only 50 milligrams of tramadol with the paracetamol. So you can give that. But I would say that you stick to paracetamol if you're giving on a long-term basis. Yeah.
Thank you.
Good evening, ma'am. I'm Dr. Mishra from Calcutta. Hello.
Good evening.
Ma'am, whether lidocaine patch is available nowadays?
Yes, it's very much available. It is called under the brand name Lidovalor. Lidovalor. Valor. Valor.
Okay.
So 5% patches are available, Lidovalor. Little expensive, but particularly used in the treatment of post-herpetic neuralgia.
Post-herpetic neuralgia,
yeah, because it's localized area and you can apply there. It's very good in these kind of patients.
Okay, ma'am. Thank you.
But there are certain precautions.
What is opioid rotation, ma'am?
Opioid rotation. I think that will be dealing with the class on opioids. So just
thank you, ma'am. Thank you so much. Okay, ma'am.
Good evening, ma'am.
Good evening.
Yeah. Now I wanted to know, like, how much, like, in tramadol patients do suffer from like serotonin syndrome also, right? So what's the percentage, like those are basically patients suffering from this serotonin syndrome, and which case scenario should we basically avoid or should not give tramadol?
See, I did mention that patients who are on tricyclic antidepressants and all, the seizure threshold can be reduced. But I think, I've used tramadol for a long time. I've not encountered this, but I think in the conventional doses, I don't think we need to be worried about that serotonin syndrome. It's I've not encountered it, and I've been giving it for ages, So I think maybe when you give it on I don't know whether it's given in the ICU that you get it more often, but in the routine doses that we give, we hardly encounter. But you have to be cautious when you're giving tramadol. And like I said, if you're giving it IV, then you give it over maybe about 10 minutes you give the whole thing and not just as a bolus shot. But also you should not exceed 400 mg per day.
Thank you.
Ma'am, if I'm not wrong, if I remember right, the percentage, Dr. Pranav, is somewhere 0.01 or 0.1. It is something like that. It's that rare.
Okay, sir.
It's there in PCF 7, palliative care formulary 7. That percentage is mentioned. I think it's 0.1%.
Thank you, Deepak. Thank you for
that. Hello, madam.
We have. Yes, please proceed.
Yeah, ma'am, I want to ask regarding lidocaine or ketamine infusions, ma'am. what monitoring is needed, and what is there any protocol, like how to give the infusions, like how long can we put the patient on infusion?
Okay, see where this lidocaine infusion is concerned, normally you calculate 5 milligram per kg, and that dose of xylocard, okay, the one that does not have the preservative in it. Huh?
Yeah.
Xylocard should be added to 500 ml of normal saline and give it over 1 hour. Okay. And the monitoring we need to do is basically cardiac monitoring and CNS monitoring. You know, whether they're having any CNS toxicity, like perioral analgesia and all the twitchings and all, or are they having any ECG changes? That's all. So it's a daycare procedure. You have to do it with a cardiac monitor, and then you can send the patient home. Now, this infusion can be repeated after 2-3 days. You can repeat it again and give 2-3 times like this to see whether the pain is coming down. Okay. So it is basically for those kind of neuropathic pain that is not responding to the first line treatment. That is when we use ketamine. Also, you have a regular ketamine infusion which you give 200 mg over 24 hours as in a syringe pump, or you give what is called a burst ketamine for very refractory neuropathic pain. I'll discuss that in my next class, how you give a burst infusion.
Okay, ma'am. So if the patient is responding and the neuropathic pain recurs, so we can give it like a monthly dosage also for them.
Yeah, but if it's responding to the local anesthetic, then you can add a drug like mexiletine, which is acts on the sodium channels. No, you can add that and control the pain. Okay.
Okay. Thank you, ma'am.
And ketamine also, oral ketamine is available. So maybe you can switch over to oral ketamine.
Sorry, ma'am, Dr. Mishra from Calcutta. I have another question. Do we use oral buprenorphine, ma'am? We don't use. Previously in 90s.
No, they have, 1 minute, they have sublingual buprenorphine.
Sublingual, yes.
Yeah,
yes.
yeah.
We were
That
giving,
is there.
Ma'am, we are giving TDJ 0.2, 0.4 milligram sublingual in intractable pain. Nowadays, we are practicing that, or
it can be given. It has been mentioned that sublingual buprenorphine can be given in addition to transdermal buprenorphine.
Okay. Thank you, ma'am. Thank you so much.
Ma'am, we have a string of questions in the chat box as well.
Shall I open my chat and see? Shall I open my chat?
Yeah, sure, ma'am. I can read it out for you as well, ma'am. So Dr. Rahul is asking, is radiation in bony metastasis, is it included in any of the is like in step 4 or something, or is it considered as something else, like an adjuvant or something? Radiation in bony metastasis.
Bone pain is an these are all adjuvant therapies. Okay. Like I said, the adjuvant drugs are given for the pain that is not nociceptive. Okay, so the bone pain, bowel obstruction pain are all considered adjuvant treatments to the basic analgesics. So even radiation, palliative radiation is an adjuvant therapy.
All right, ma'am. Thank you, ma'am. Dr. Manoj is asking, what are the options to treat excruciating brachial plexopathy pain and lymphedema due to CA breast? You had mentioned about a patch being used, which may be effective. Are there other options as well which we can explore?
See, brachial plexopathy is because when they were giving the radiation, the brachial plexus has got cooked, okay, by the radiation. And that is what has caused the neuropathic pain and the brachial plexopathy. There will be a combination of motor as well as sensory changes. You know, sensory would be very severe burning, allodynia, and maybe even tingling numbness. And motor will be the complete, power will be reduced quite a bit. So how do we treat it? Okay, now that is a good question to ask because it's very difficult to treat. So you will find that invariably all these muscles have become like hard, like very, very rocky hard these muscles have become. So you can somehow try to, of course, you have to give the antidepressants and anticonvulsants and, SNRI may be useful along with high dose of anticonvulsants. But in addition to that, we can try to release these nerves by relaxing the muscles around it. So, targeted dry needling of the muscles, where because of the scalene muscles through which the brachial plexus are emerging, the sternocleidomastoid, the trapezius, dry needling of these muscles can help in addition to treating the plexopathy, because the options are very few in these kind of patients. So I do what is called dry needling, in which we are needling the tight muscles. Okay. So sometimes the nerve can be entrapped anywhere, here, anywhere in the neck or in the arm. And their dry needling of these muscles are, to a certain extent, can reduce the pain. Otherwise, it's a very, very excruciating pain, and it reduces the quality of life a lot.
Thank you, ma'am. Ma'am, we always try using the safer drugs for as short a period of time as necessary, and the shortest in the smallest dose possible. So there is a question Dr. Jasmine is asking: is paracetamol and NSAIDs belong to step 1 useful only for nociceptive pain, or is it going to be effective for neuropathic pain as well?
No, it is only for nociceptive pain, and it is not an anti-inflammatory drug. It is not NSAIDs. It doesn't come under the category of NSAIDs. It is a pure analgesic antipyretic drug, and it is not for neuropathic.
Thank you, ma'am. Ma'am, there's a question that how long can one continue being on antidepressants and anticonvulsants? In our home care settings, we have seen people, especially elderlies, they continue complaining about the pain, and then we continue them for months together. But is there a fixed duration, or should we try cutting it down as much as we can? How should we approach it?
Which drugs are you talking about?
Ma'am, a combination of antidepressants and anticonvulsants for neuropathic pain. How long can one continue it safely?
Okay. See, it all depends upon whether the patient is responding or not. If the patient is responding, then after escalation, you can de-escalate the doses. Okay. But otherwise, you have to keep a watch on the renal and liver function also. But if you can come down to a baseline dose and then continue it, I don't think there is any harm in giving it for a long time. But definitely, you should keep assessing the pain. And if its intensity is coming down, you should try to de-escalate the dose.
All right, ma'am. Ma'am, is there any prescribed periodicity in which we should look for the renal or hepatic functions or something?
I would say every 3 months. Every 3 months, just keep a watch on it. That is, I'm not going by literature. I'm going by my own this thing. That's it.
All right.
If they're on long term, then I think every 3 months you can check the kidney and renal function.
Okay. I was just thinking about there is so many in home care situations. People who are into poverty. I mean, we give the medications to them, and then we usually don't ask them to get any investigations done unless some symptoms start developing. So I was just wondering that, is it still
depending on the
necessary?
socio-economic status, maybe you can increase that time also. Okay.
Ma'am, there's a question, practical question. Diclofenac gels are available. Many times we give it for, especially in elderly people, they always come asking for that gel for application. Is it the amount used which is more important, or is the area of spread? Is there something like that? Or it is just as a person wishes, they can apply? So we're looking at effectivity over here. If we apply more quantity, is it effective, or we spread over a larger area, is it more effective? Is there something like that?
Not as far as I know, because the absorption is not complete, right? Only part of it is getting absorbed, right? So it is, I think there will be a good safety margin also, like, unlike when you're giving it orally or giving it parenterally. when you're applying topically, a certain percentage only is getting absorbed. So I think there is a safety margin. But I think unnecessarily we should not apply large quantity also.
Dr. Chaitanya is asking, what are the contraindications for lidocaine or ketamine infusions?
Contraindications. Lidocaine, history of convulsions, maybe you should not use, because this is one of the side effects of lidocaine. Allergy is very rare. But if there are conduction problems in the heart, then I think we should not use it, because it can affect the heart. The main toxicity is cardiac and neuro, right? And allergy as such is very, very rare in local anesthetic. So I think if they have an underlying cardiac conduction problem, or if there's a history of convulsions, maybe we should avoid lidocaine. And where ketamine is concerned, also patients with raised intracranial pressure, and those with already hypertension, because it has got a, it can cause tachycardia and raise an ICP and all those things. No? So maybe in such patients, we should not use ketamine.
All right, ma'am. Dr. Ravi Shankar is asking. Yes, please, sir.
Ma'am, I have one question. We come across a lot of neuropathic pain patients in our pain OPD, and please guide us and suggest us a textbook which will be helpful for us to go through for management of neuropathic pain.
Textbook?
Yes, ma'am.
I think more than textbook, if you just go into internet, you will find a lot of articles, review articles on this, you know.
Okay, so, okay, ma'am. Okay, ma'am.
So you just look up management of neuropathic pain and you will find plenty of articles on the net. Peer-reviewed articles.
Thank you, ma'am. Okay.
Ma'am, shall we go ahead with the case presentation
because now there's
because
only 15 minutes
20
left.
minutes. Yeah, hardly 15 to 20 minutes. And shall we take questions later, ma'am, after that?
Okay.
Sure. Dr. Akshay,
yes.
Are you online? Yeah.
Yeah.
Please,
am I audible?
Over to you. Yes, you're
Am I audible?
Yeah.
Okay. Good evening, ma'am. Good evening, all the seniors. Today, the case which I would be presenting is on a topic of management of pain and SAIDs. The case is an 11-year-old female. The diagnosis is rapidly growing bony mass. Probably it's a osteoblastoma, which is in the upper end of left tibia. And she is posted for a needle biopsy under general anesthesia. Presenting complaints, patient has mild to moderate pain in the left knee joint, which is gradually increasing in intensity since last 2 months. Small hard swelling below the left knee since the same duration. History of the presenting illness. The pain started around the left knee following a fall during a football match, which slowly kept on increasing in intensity since the last 2 months, and also it radiates toward the lower left leg. The pain is burning and sharp shooting in nature. The pain aggravates on walking and subsides with the cold compression and rest, and with the painkillers. Since the last 15 days, the pain intensity has increased even at rest and during night, which has led to significant sleep disturbances. The child has been exhibiting a limping gait while walking since the past 10 days. On examination, general examination, she is awake, alert, cooperative, but anxious. Febrile, blood pressure is 110 by 60 mm of Hg. Heart rate is 100 per minute. Respiratory is 17 per minute, and saturation is 99% on room air. Systemic examinations are all within normal limits. Local examination, on inspection, there is a limping gait, swelling over left tibial tuberosity. Range of motion, both active and passive flexion of the left knee is restricted, and these movements initiates excessive pain. On palpation, swelling is diffuse, hard, bony, with a smooth surface. Skin above the swelling has a normal temperature. The treatment and the significant investigations which were done. The investigation, since she has come for a biopsy, the routine blood investigations were normal. X-ray knee was done by the orthopedic and the onco-orthopedic surgeon. MRI knee was also done, which were the blood pictures were normal. The treatment previously, which was given before she came to hospital, a private practitioner advised her rest, cold compression, and oral NSAIDs and oral paracetamol was advised, and topical analgesic gel was given to her. The psychosocial aspects. She's a 11-year-old female. She was very anxious when she came to the pre-anesthesia checkup. She had sleep disturbances for last 1 to 2 weeks. She was not able to attend her schools regularly. The daily activity was restricted because of both increase in frequency as well as intensity of the pain. She was unable to play with her friends, leading to mood swings. She was lonely at home during the daytime, and she had episodes of crying and restlessness. Fear of losing limb, as it was conveyed to the mother by the private practitioner. The medications which were given, tablet Hyphenac P, that is aceclofenac 100 milligram with paracetamol, which she was taking twice a day for last 10 days. Pan 40 was given OD for last 10 days. Diclofenac gel applied locally, which was intermittently applied. And prior to consulting the doctor, the child was on some Ayurvedic medications which her mother could not specify, and she could not specify the duration which she was taking the Ayurvedic medications. So the main concern is her age. She comes in a pediatric age group. The safety of use of NSAIDs for a long time. What would be the next line of analgesics which can be prescribed, since the pain is not decreasing in intensity in spite of regular intake of paracetamol? Psychosocial aspects on the child, as pain is producing interference in the normal daily activity of an 11-year-old girl. So to summarize, 11-year-old female presenting in our pre-anesthesia checkup clinic with complaints of mild to moderate pain in the left knee, which was gradually increasing in intensity for the last 2 months, along with a small hard swelling below the knee, left knee joint since the same duration. Since the past 15 days, the pain intensity has increased along with the pain at the rest and during the night, which has subsequently led to significant sleep disturbance. The child has been exhibiting a limping gait while walking since last 10 days. She has been advised rest, cold compression, NSAIDs, and oral paracetamol. Presently, this patient has been posted for a needle biopsy for the diagnosis of the lesion under general anesthesia. So provisional diagnosis is rapidly growing bony mass in the upper left end of the left tibia. Discussion points. Do we need to provide palliative care to this patient at this moment? What can be done to manage her anxiety and sleep disturbances? How can we get her to interact with her school friends more frequently so that she does not feel left out? And what should be our plan for further pain relief? Thank you, ma'am.
Thank you, Dr. Akshay, for that presentation. So you said, you asked whether the person needs to be given palliative care at this point of time.
Yes.
What is your opinion on that?
Sir, I think the patient gives an history of last 2 months, and her intensity of pain has increased for last 10 days, and we do not have a definitive diagnosis at this moment. I think she might require palliative care because she is complaining of anxiety. She has insomnia, and since, as we know, that she is a pediatric patient, she is not able to meet her friends. So basically, psychological aspect of the disease, because of the disease, has to be taken care of. So I think she requires a palliative care even at this stage of the disease.
So as you know, the latest model by the book How We Go is the moment the symptoms start developing and the curative aspect of treatment starts happening. Along with that, hand in hand, we start giving the palliative aspects as well. Like you said correctly, this is a child who has been in pain for about 2 months now, and there are issues, especially being a child. Just out of curiosity, what were the most difficult things which you encountered when you were interacting with this child?
So first of all, she was not allowing anyone to touch her leg. She was not allowing anyone to examine her leg. Because there were a number of people who have already examined her, and she was becoming more conscious. She had this point in mind that she probably heard her mother having a conversation with doctor regarding probably amputation of the leg. So she was more anxious about her leg being amputated. So even if for a normal general examination, she thought that doctors might amputate her leg. So that was the very important anxiety which I felt that the patient has. Second, the pain intensity at night, probably she's not able to sleep, so she is complaining more pain at night. And disturbed sleep, she was not able to meet her friends. So these 2-3 points are what I felt was very important at that moment.
What were you able to do? Now, this is a difficult situation, obviously, when you have a child in front of you having issues like this, which we are not on a routine basis, which we encounter. What did you do for this child?
So basically, I asked her mother and father to be with her when I was counseling. I basically introduced myself. I made sure that she is comfortable with me, and I actually gave her confidence that I am the anesthesiologist who would like to bring her pain as low as possible. And I'm not a treating surgeon. I'm not going to hurt her at this moment. And we do not have any diagnosis right now. Whatever her problems are, we are here to treat her. And with 20-25 minutes of counseling, her anxiety came down, and she started giving her history herself, because she's 11-year-old and she could communicate well. So that is how I started my counseling session initially in an anesthesia checkup.
That's wonderful to know. Ma'am, yes, ma'am, please.
No, what I was thinking is Dr. Akshay did a really good thing, because this child is more fearful and anxious. And like we know all about cancer pain, that it is total pain management, right? So
Yes,
we
sir.
have to treat not just the physical part, but the psychological and the social aspects also. And the first and foremost thing that he did, which is absolutely bang on, is winning the rapport of the child. By telling that I'm not the surgeon, I'm here to, as a friend and as a, just want to know, we want to just decrease your pain. And, that's exactly what you should do. Establishing patient rapport itself is the biggest step in this pain management. And when she gets confidence in you, she'll be able to open up. Otherwise, they will just withdraw. They won't even communicate with you. So I think it's a very good thing that what you have done. And I'm also an anesthesiologist, and we go by the ASA physical status, right? And
Yes,
now
sir.
I've got a complete rethink about it. It is not ASA physical status. We have to, people who are coming for surgery are very anxious. The relatives are anxious. And it is not, we are not assessing only the physical status. We have to assess the whole person, the degree of anxiety that they're having, the fears they're having. So, it's a completely different kind of a thing that we should approach. And I think you have done a very good job. By the way, I just wanted to know what is the NRS of the child, the pain score.
Ma'am, yeah, ma'am. Sorry, I could not put that score in the case presentation. Ma'am, her daytime NRS before she took the medication was 4, but at night she had an NRS of 6 to 7.
Yeah. So obviously the fears and anxieties are contributing to the not only to the increasing the pain, but also for the insomnia. So if it is 4, you can easily manage with step 1 drugs, and then at night you can give an anxiolytic for this child, which will allay the fears and improve sleep, and that itself can also bring down the pain. So I think in addition to this thing, you may have to add some kind of anxiolytic, some counseling. What you have done is right, but maybe you could have a counselor to go and talk to her also, and,
Okay.
Allay her fears. That's the most important thing that you can do. Because I can understand what this child is going through, cannot play, cannot run around. But if you can encourage her friends to come over and talk to her and be with her, see, the psychosocial aspect has to be dealt with in this particular child. A pain may not be as bad as the psychosocial part of it.
Ma'am, she was not. She thought that this anesthesia checkup was basically for amputating her leg.
I know that.
She was not convinced that we are just going to do a diagnostic procedure.
Yeah. See,
And
that
we
is
are
how
not.
the magnification has taken place in her mind. And that is where it was so important for you to, establish a rapport with that child, saying that we are here to help you and decrease your pain. That
Yes,
kind of thing.
yes, ma'am. Ma'am, can we continue the NSAIDs for another 2-3 weeks till the time we get the reports of biopsy?
Yes. That much you can easily do in a child like that. They should ensure the child is well hydrated. That is important.
Yes, ma'am.
But otherwise, a child will not have any risk factor for NSAIDs, because
Okay,
in this child, NSAIDs will work much more than paracetamol for her.
Ma'am, this child would definitely, if the biopsy reports comes out to be positive, this child is definitely going to go for a probably resection of the SOL, maybe implant, orthopedic implantation and all that. So she would be having this off and on pain for maybe another 2-3 months. So as per the duration of pain, we might enter into a chronic pain along with this complaints of anxiety and insomnia. So can we preemptively, as we do in a acute pain, preemptive analgesia, can we start something preemptive?
Yes,
so that
you can.
we do
And
not.
also, it's very important to treat the post-operative pain, because untreated post-operative pain is what is predisposing. In 40% of patients, they go in for chronic pain. Okay, so the acute post-operative pain has to be treated well, because now you have access to IV drugs and things like that. Make sure that the child doesn't have any post-operative pain. That itself can predispose to chronic pain in a later stage. Okay, so preemptively you do whatever you want. And see, we have such good medications now, which we had not had earlier. So it is so important to tell them that you will be having the biopsy, but we can assure you that you won't have pain. And then you make sure that the patient doesn't have pain. Because at that time, the IV line is going on, you can give whatever you want, and make sure that the child doesn't have pain. That itself will infuse confidence in this girl, even if she has to go for another surgery, she'll know that, okay, I didn't have pain during this present thing, I won't have pain. So these kind of things also very important to look at the person and not just a disease. Okay, we are not looking at that bone and that knee and all. We are looking at the whole person. That's very important.
Yes, sir.
Thank you so much, ma'am. It's wonderful to see that the participants have already started
I
getting a
think
hang
this
of
time
total pain.
there was a lot of barrage of interaction, I think, and
Yes,
very,
ma'am. There is
very.
still more. There is still more, but then some of the questions on opioids, ma'am, we'll look at the next session because anyways, we will be going in depth for it.
Yeah.
Ma'am, we are in the last 1 minute of our session. Just one practical question from Dr. Pranav. How long can a person be given NSAIDs?
There is no definite thing, but if a person has got, like a young person who has no other comorbidities, you can continue it as long as you're monitoring the renal function. But elderly people or people, like I told you, the risk factors, if you go through my presentation, you will see the various risk factors for NSAIDs. The GI risk factors, the renal risk factors, and the other risk factors, the cardiovascular and the thrombotic events and all. So if the risk factors are there, then you have to be very cautious. But if a person has no risk factor, then you can, you can give it for, at least for a couple of months at least, I think. Okay. But if there are risk factors, you have to be very cautious. If you go through my slide, I've listed out all the risk factors for renal toxicity and GI toxicity. Patients on anticoagulants, patients on aspirin, or those on, drugs that are, that creatinine clearance low, age, dehydration, so many risk factors are there. So based on that, you have to. Thank you.
Ma'am, one quick question, ma'am. How long the phantom limb pain persists, and how do we treat phantom limb pain?
That's a very, there are a lot of ways of treating phantom limb. I would suggest in my book, Conquering Pain, I have addressed that issue. So you maybe buy a copy of my book.
Ma'am, what is the name of the book?
Conquering Pain by Mary Abraham.
Okay,
it's available on Amazon. It's only 100 rupees now, by the way, Amazon.
Okay,
महंगा नहीं है.
Thank you, ma'am.
I've addressed the whole thing of phantom limb and how the pain management is there.
Thank you, ma'am. Thank you.
Thank you so much, ma'am, for that wonderful session. There are still questions coming in, but then due to lack of time, we'll be looking at another session with ma'am pretty soon. So that time we can look at further questions. And there is always the WhatsApp group in which all of you are there. If there is something really pressing, please feel free to ask your questions so we can try getting answers. So ma'am, thank you so much to take out so much time from your busy schedule. Always wonderful learning for me as well, for all of us, I'm sure. Looking forward to your next session, ma'am. Thank you so much.
Thank you, Deepak. Thank you for those nice words, and for Shri Priya for